subscribe now and press the bell icon. Never miss an update.
Welcome to Health Live at Seniors Today. We are delighted to have here with us once again Dr. Ankur Phatarpekar. Dr. Ankur, as you know, was there with us in the past as well. And today he is going to speak to us about heart failure. And this is the Heart Failure Awareness Month. And we thought it would be good to have him here. A little about him. He's an alumnus of the Seth GS Medical College. He has performed over 300 PCI procedures as primary operator, including 50 angioplasties and myocardial infarction. He has significant experience in managing chronic total occlusions and use of intravascular ultrasonography. Dr. Phatarpekar has attended workshops on OCT in coronary arteries under Dr. Guglielmo. He has performed more than 100 balloon mitral and has performed device closures of ASD, PDA and VSD, balloon procedures of aortic and pulmonary valve and coarctoplasty. He has been active in the upcoming field of oncocardiology, having experience of treating a special subset of cancer patients with long-term cardiac issues due to chemotherapy. Today, Dr. Ankur is going to speak about heart failure. Over to you, Dr. Ankur, and welcome to Health Live at Seniors Today once again.
Thank you. Thank you for having me.
Last time when we met with you, you were in your hospital gear, etc. And today, we've managed to get you out of it. Does it mean that, there's less pressure in hospitals, or is it just that you've been able to take off?
It's a regular day.
Regular day.
It's a regular day. You get up, you go out of the house, go to your cath lab, wear on your gloves and start your angioplasty.
It is. I guess it's the same thing like for us in journalism, where you treat every day like a different day, and you treat stories that are happy and sad the same way. I'm saying that's the way you're talking about. You go ahead and go to an angioplasty.
I think it was a bit of Rudyard Kipling in your lines. I mean, if poem of Rudyard Kipling is the same, it says that you treat everything as the same. So yes, it's you live in the moment. I mean, while doing an angioplasty, it's an adrenaline rush, because if you go wrong, you can lose the patient. So high degree of awareness about about what you're doing, a high degree of concentration, and yes, I mean, we do it day in day out, so we are trained and we're used to it.
Right. And tell me, I was reading about the COVID cases. I've been hearing about some people, some friends and their families contracting COVID. Are you experiencing an increase in numbers?
I personally, being a cardiologist, I don't see that many fever patients, but when I go to hospital, especially Wokhad Hospital, where I do go regularly every day, there they have this special COVID ward, but we've not seen any admissions till now. Maybe these patients are contracting COVID on OPD basis, but they're not getting serious, at least till now. But that doesn't mean we should not take care, because nowadays what I'm seeing is people are not wearing masks even while coming to my OPD. Yeah, so it's very important that we at least mask up and take our boosters.
And how does a doctor like yourself take care? You obviously must be masking up all the while.
Yeah, I keep my N95 on even now. I do that. I am quite disciplined in wearing my mask properly, and whenever I'm communicating with people, especially because I meet a lot of people, not only the patients but also the relatives. So I keep my mask on. I've taken my booster shots. I take all the precautions, whatever is possible. Use sterilium. All these things I do regularly, and I would also ask all the listeners to follow it, to at least mask up and take their booster shots.
Yeah, I guess booster shots is something which perhaps most of our people would have taken up, but I'm not very sure whether everybody is masking up well enough. And I think that's what it is. Tell me, just to understand, would you mask up before before COVID happened, or you wouldn't? In the hospital, in the OT, obviously you mask up, but
we wouldn't.
You wouldn't do that.
Yeah, in the OT we completely mask up. I mean, we have all the gear on, and as a cardiologist, we wear lead aprons because we work under radiation. So we have the entire head cap, the thyroid collar, everything, including the mask. But outside of the OT, we never used to wear. But now it's a point, as a rule, even the hospitals don't take you inside without a mask. Even they have been following this.
Doctor, I must confess, I did not know there's a heart failure awareness month. But since it is there, I thought it would be good to have someone like yourself who's there, who's committed to cardiac care across various Mumbai hospitals. So to speak about it. So if you could speak about heart failure, and then I would request all our attendees here to post their questions in the Q&A tab. If you put in your, as always, if you put in your age and your gender, then Dr. Ankur could give a more considered reply. So please post your questions. Feel free to post your questions on the Q&A tab or in the chat window, and then I will pose the questions to Dr. Phatarpekar. Over to you, Doctor.
How do you want to do it? Like, I have made a small PPT, just some bullet points. So do you want to stop me in each slide, and should we have?
You go ahead. You go ahead with the presentation, and then we can. You have rights to the presentation, so you can go ahead and do the presentation, and then we'll take it off from there.
You're able to see my screen?
Yes, you are. Yeah.
Okay, fine. So before we go to heart failure, these are the terms we usually come across. Heart attack, heart failure, cardiac arrest, stroke. So what happens is, many times people use these terms loosely for one another. So let me clear out what each of these terms are. So heart pumps blood out of the heart, whatever it receives from the lungs, the oxygenated blood. The left heart pumps and throws it outside. So heart is nothing but a bunch of muscle which pumps and ejects the blood out of the heart into the entire body system. Now, heart also requires blood. So the arteries supplying the heart are called as coronary arteries. So any blockage in these arteries, when the arteries get blocked to 100%, 99, 100%, the blood flow to the heart goes down. And at that time, the muscle of the heart gets damaged, and this is called as a heart attack. So a heart attack is acute closing of one of the arteries supplying your heart. And because of this, the patient might experience chest pain, sweating, uneasiness, breathlessness. And if there is a significant area of heart, is compromised, and because of that, heart as a pump, if it stops pumping optimally, what happens is it is receiving blood from the lungs into the heart. So because it doesn't throw out, everything dams back into the lungs, and the patient's lungs get filled with water. This is called as pulmonary edema, and this state is called as heart failure. So a heart attack is due to blockage of the arteries, but if it is very distal, it might not cause a heart failure, but it's very proximal where it's beginning, and the large area of the heart is under jeopardy. That time the heart stops pumping properly, and because it does not pump properly, all the fluid gets dammed in the lungs and you start getting breathless. That state is called as heart failure. And what is cardiac arrest? Cardiac arrest is heart suddenly stops pumping. Not the heart failure is because of decreased pumping of the heart. Cardiac arrest is because of stoppage of any pumping of the heart. That happens when you have rhythm disturbances of the heart as well. When the heart goes very fast pumping, like it's like 170, 180 beats per minute, or maybe it goes very slow, that is 20, 30 beats per minute. In that case, slowly and steadily, the patient might go into this state, which is called as a cardiac arrest. So heart attack, if the heart fails as a pump, it's called heart failure. And finally, if nothing is done and the patient's heart rate goes either very fast or very slow, cardiac arrest. One more term which I want to bring in is stroke. Stroke is actually not related to the heart. Stroke means if you get a paralytic attack, that's called as a stroke. So people usually, many times I hear this, he's got a stroke, when they actually want to say that it's a heart attack. So these are the terms: heart attack, heart failure, cardiac arrest, and stroke. Now, what is heart failure? Heart failure is often called as congestive heart failure. Where is the congestion? The congestion is in the lungs, not in the heart, mind you. So heart doesn't pump out all the blood gets dammed in the lungs, it goes into the lung space where the air is there and gets filled with water. And that state is called as congestive heart failure. It might occur acutely or chronically. Acutely means suddenly in a span of few minutes. Chronically means over a period of days and months. Often the heart is not able to pump sufficiently to maintain the blood flow and to meet the body needs. So two things happen. One, it doesn't pump out. That's why the patient gets less of blood to the other organs. And second thing is because it doesn't pump, everything dams back into the lungs and the patient feels breathless. Now, what are the statistics? More than 20 million people have heart failure worldwide. And mind you, untreated heart failure, if you don't treat a heart failure properly, the mortality rates or the death rates are worse than a treated breast cancer patient. So 50% of them would die in next 2 years if they are not treated correctly. So it's very important to diagnose, because sometimes the symptoms of heart failure not be classical, like breathlessness. They might just come with unexplained fatigue. So prevalence of heart failure in India is due to coronary artery disease. Coronary artery disease means any blockages in the arteries supplying the heart. Hypertension, blood pressure. So patients who are having uncontrolled blood pressure, the heart size goes big. And because of that, the heart again does not receive good blood from the lungs, and patient starts feeling breathless and gets swelling of the feet. Obesity. Diabetes. Diabetes is #1 killer of the heart. Tobacco and diabetes are two risk factors which really cause a lot of heart ailments. Rheumatic heart disease. Rheumatic heart disease is basically valvular heart disease, which we used to see a lot in the olden ages. Now we see that also, but it's more seen in the rural part of the country rather in the cities, where the walls of the heart are affected, and because of that there's leakage in the walls. And from 1.3 to 4.6 million with an annual incidence of 491,600 to 1.8 million. And heart failure is the leading cause of hospitalization in people older than 65 years of age. So what are the types? As I told you, it might be acute or it might be chronic. Acute means suddenly you get a heart attack, the heart stops pumping as properly, and your lungs get filled with water, and suddenly you become breathless, the oxygen saturation goes down. It's called as an acute heart failure. Now, what is a chronic heart failure? Slowly and steadily, because of diabetes, the blockages develop slowly. They from a 70% they become 80, 90. Slowly the blood goes down to the muscle stops pumping, and then the lungs and the lungs get filled with water. But this time chronically, you get abdominal bloating and swelling. So that's a chronic type of heart failure. This we commonly see in our OPD, and acute heart failure is what we commonly see in our ICUs. Left versus right, that's also very important. Right heart failure is also nowadays a very important cause. People who are morbidly obese, people who have sleep apnea, that means at the night time they snore a lot. What happens is the right heart gets affected. Also, right heart can get affected because of chronic lung conditions. So you have any COPD, that is chronic obstructive lung disease, asthma, bad lungs, ILD, your right heart gets affected more than your left heart. So both are important, the left as well as the right heart, to function optimally. Now, what are the symptoms? Very important. The most classical and the cardinal symptom would be breathlessness. So patient would complain of breathlessness on more than accustomed activity. That means if you ask the patient to walk in the house, they'll not feel breathless. But you ask them to climb 1 flight of stairs, 2 flight of stairs, they'll become overtly breathless. So what they do is, many a times the patient does not walk that much. He starts using the lift, does not use the stairs. He does not move around much. Wherever, if he gets on in the apartment of the building, he'll catch a Uber or a taxi, ask for his car. So he or she would restrict the activities. Pedal edema, that means swelling of the legs. So as I told you, when the heart doesn't pump out, everything goes it dams back in the lungs. Again, it dams back in your abdomen, you get bloating, and finally your legs, because the venous congestion sets in the entire system, and therefore you can get swelling of the feet. So many a times chronically patient comes with just swelling of the feet. So any swelling of the feet, you need to rule out cardiac disease by doing a good echo, seeing whether the patient has any blood pressure, any valvular leakage. Third is fatigue. Unexplained fatigue could also be a cardiac symptom. So if you're feeling overtly fatigued, even after walking few steps, you feel fatigued because the heart is not throwing blood outside. It's not pumping. It's not ejecting blood outside. So the muscles, your various parts of the body don't receive blood, and therefore you will feel fatigue. Chest pain can also be a presentation, especially when you have a coronary artery or a blockage in the heart. Lack of appetite is also one of the features of heart disease, of heart failure. Once you treat the patient, the appetite starts improving. That's first sign of, the patient is improved. So what are the investigations? How do you find out that the patient has a heart failure? So basic investigations first. The most important thing would be a good clinical examination, checking the lungs for a doctor. The doctor will check the lungs, the heart sounds, whether any swelling of the feet is there, and then advise proper relevant investigations. So ECG is one thing. So ECG might give you a pointer, but it does not in 100% of the cases pick up heart failure. So the investigation of choice is a 2D echo. A 2D echo will tell us what is the pumping or the ejection fraction of the heart, whether it's 20%, 30%, 40%, anything less than 50%, or now there are new categories wherein even with the normal pumping, you can go into heart failure. So that's called as diastolic dysfunction. Let's not confuse, I'll not talk much about that, but what is important is ejection fraction or the pumping of the heart. You'll come to know on a 2D echo. Second, you'll come to know whether the heart, what is the heart size, because because of blood pressure, what happens is if the patients have uncontrolled BP, all the pressure comes on your heart and the heart starts becoming big. And because it becomes big, it becomes stiff as well. And therefore, the heart will not receive blood, and therefore the lungs will get congested and the patient will start feeling breathless. So size of the heart will also be picked up on a 2D echo. Third is any valvular leakages. So severe leakage of the walls, because as you age, the walls get calcified and you might get leakages in the wall. Severe, it can cause a heart failure. One medical blood test, which is now recently we use it quite often, is NT-proBNP. So many times patients have lung issues and cardiac issues, and you don't know which of the two is contributing to the breathlessness. Then you do this test. This is specific for the heart. If the NT-proBNP is raised, that means the cause of breathlessness is heart more than the lungs. So nowadays we're using this investigation, especially with patients who have bad lungs and also heart issues. Now you don't know the patients who are breathless, whether you should nebulize the patient or give injections for decreasing the heart failure. So we do this investigation, which is NT-proBNP, and then we find out whether the cause is a heart and treat accordingly. Other tests like angiography is necessary in certain cases, especially if it's a diabetic, tobacco chewer, in that case, or smoker. In that case, you would require to profile whether there's blockage in the heart or not, because opening the blockages will improve the blood supply, and therefore the ejection fraction or the pumping and the signs of heart failure would go down. Mind you, all these symptoms, the breathlessness, chest pain, the breathlessness, the abdominal bloating, or the swelling of the feet can also be seen in other conditions like kidney failure. So it's very important to rule out and do a complete checkup when you find a patient who has breathlessness and swelling of the feet. Now, how do you manage a patient of heart failure? So till now, we found out what's heart failure, what are the terms, then we found out the statistics, then we found out what are the symptoms and investigation. Now we come to management. So how will you manage? Fluid restriction, very, very, very important. So a heart failure patient whose ejection fraction is just 30%, 35%, cannot drink a lot of fluids. He has to restrict the fluids. So fluid restriction is very important, because if we load the heart with a lot of fluids and the heart is not pumping out, everything will dam back in the lungs again and the patient will start feeling breathless. Salt restriction, again, one more important thing, because if you take more of salt in your diet, especially your papads, your pickles, all these things, we have high salt content. So if you take a lot of salt, you will drink a lot of water, and that will again increase the heart failure symptoms. There are 5 medications now available. One is the beta blockers. These are drugs which prevent the heart from failing and causing bad rhythms of the heart. There's this new blockbuster drug which came in 2016 called as Ernie, or these are the group of drugs which is called as Ernie, Vimeda. This is a wonder drug. After this drug came in, our heart failure patients benefited so much. I always keep on saying that how there is progress in stent technology, in surgeries, in the same way medical tablets and medicines have also improved so much, because there's so much research happening. Patients, I was a lecturer teaching faculty in KEM hospital when this trial was going on. And before it came into the market, we were using this drug, and we used to see the benefit of this drug. When we started these patients on this drug. So Vimeda is one blockbuster drug for heart failure. There's something called as mineralocorticoid receptor antagonist, or MRA. Aldactone is the drug which decreases the fibrosis of the heart. The heart in the heart failure becomes globular, it becomes round. So it makes it lean, oblique, oblong, and because of that, the heart pumps effectively. So MRA is one more agent. Diuretics very important if you get congested, if the swelling of the feet, you give Lasix or Ditor, you take out the fluid from the body and take it out from the renal system, or your urination increases because of these drugs. There's this new drug called as SGLT2 inhibitor, which is actually, it came as a diabetic drug, but now it's become a heart failure drug and a diabetic drug. So even in patient who don't have diabetes, we are using this drug because of one medicine called as rosiglitazone. What the US FDA found that when rosiglitazone was given as an anti-diabetic agent, it caused more of heart failure. So after rosiglitazone, the US FDA started that every diabetic drug needs to prove its cardiac safety. So SGLT2 inhibitors, because before they came into the market as a diabetic drug, they had to prove the cardiac safety. So during the trials, it was found out that not only were they safe, but they were also very, very effective in treating heart failure. So this is one more group of drugs which was initially a diabetic drug. Now it's also used as a heart failure drug. So the contents are dapagliflozin, empagliflozin, or canagliflozin. Surgical management. So like medicines have improved. There are good medications available for heart failure patients. There are also surgical and interventional therapies which have come in. So there's something called as cardiac resynchronization therapy. I do this therapy a lot. I'm a proctor for St. Jude and Abbott for this. So patients who have something called as a left bundle branch block, there's a particular pattern on the ECG. So when you put two wires inside your heart, just like a pacemaker, you can help both the heart chambers, the right and left heart chambers, to contract at the same time and improve the ejection fraction. So this is called as cardiac resynchronization therapy. It's a beautiful therapy which has come in, and this is without opening the heart. So it's a non-invasive therapy or an interventional therapy. Now there are left ventricular assist devices also. Patients who are on maximal medical management going into recurrent heart failures, for them there is something like an added heart. So you have two hearts together. So there's this device called as HeartMate 2 or HeartMate 3. So what it does is it's a surgical therapy wherein you attach this device into the apex of the heart, and there is a motor and a propeller which helps in. It acts like there are two pumps. So heart is one pump, and the second pump is this HeartMate 2 or 3. So HeartMate 3 is a very costly device. It's almost one CR Indian rupees just for the assist device. But patients after HeartMate 3, you can in US you have these patients, they keep on charging their batteries, and they have to remove the battery and put a new battery, and they go for swimming with this left ventricular assist device. So it has become a destination therapy. That means patients normally were waiting for heart transplant on the list, but many used to die. But now after HeartMate 3, these patients have this therapy in which they would wait till they get a heart transplant, a heart for a heart transplant. So this is a beautiful therapy. In India also, in Bombay, there are very few cases which have happened because of the cost, but it's now picking up. And lastly, heart transplant. Heart transplant has come up in a big way in our cities. We are doing it in many centers like Jaslok, Masina Heart, Nanavati, Global. There are many centers around in Mumbai now doing good heart transplant work. We've had good young surgeons who have gone abroad. My colleagues who have gone abroad, trained for 7-8 years, now come back, and now they want to take up only heart transplant. They don't want to do bypasses. They don't want to do valvular replacements. They are doing heart transplant. So so exciting times ahead for heart failure patients. There's a lot of therapies which are coming in, and because of these therapies, not only medical and surgical therapies, patients of heart failure are now living longer and now have a hope which was not there even a decade back. Even 10 years back, we did not have many of these therapies. So exciting times ahead, and this is my presentation. I'll stop sharing.
Thank you very much. Thank you very much for a very detailed presentation. And I think many of the doubts that people have been addressed here. I see that everybody was busy watching the presentation because some of the things that are there are perhaps known, but they're not as known to everybody. So those of you who have questions, please put them on the Q&A tab and I will have it addressed to Dr. Ankur. I have a question here for you, Dr. Ankur, is that is the chances of heart failure hereditary? I do not have any heart issues, but in my family, there have been some cases of heart failure. Is it possible that I might also get heart failure? I'm 63.
Okay, so heart failure is a clinical diagnosis. That means there are multiple causes to heart failure. So you can have a blockage in the heart causing heart failure. You can have valvular issues which can cause heart failure. You can have hypertension which can cause heart failure. So there are many causes which in the end produce a symptom which is breathlessness, your swelling of the feet, which is called as heart failure. So heart failure, hereditary, there are causes like Barth syndrome, and these are syndromes seen in the childhood. The childhood heart failure types. They are not related to diabetes or tobacco or anything else. These are childhood variants that runs in the family. But for a 63-year-old, if you have risk factors for heart disease, like if you have diabetes or if you're a smoker, or if you have family history, which can cause coronary artery disease or blockage in the heart, which might give rise to heart failure. So rather than heart failure being hereditary, it's the cause of heart failure which can be hereditary. So if you have diabetes running in your family, or if you have family history of heart disease, that could be a reason for having it in the family.
So the question this person has asked is, Doctor, I do a detailed check every year, which is blood test, plus ECG, etc. Is there anything special that I need to take just to rule out a possibility of something building up in my body?
So what's the age of the gentleman?
63.
63.
The same person who asked the first question, yeah.
Right. So he can first all the screening for risk factors. That means he should check his blood pressure, check for diabetes, check for cholesterol every year. Then get a regular ECG done, and if possible, also if there's a strong family history, then do a stress test. Because if you do a stress test, it might you might pick up a silent ischemia. Or it might not be overt to you in terms of symptoms, but you might find ECG changes which might suggest that there might be a blockage.
Doctor, we have a question from Shrikant Kulkarni, who says, you spoke about Diator, an effective diuretic. Is indapamide equally good? I'm 70-year-old male.
Yes. So indapamide is more of a blood pressure diuretic. So if you have blood pressure, and it's a wonderful antihypertensive medication. But for heart failure, indapamide is not that good a drug. So you would use a Diator or a Lasix because it removes more of fluid from your body and from your system. So indapamide is good as an antihypertensive diuretic, but not great as an anti-failure diuretic. So if you have a heart failure, Diator or Lasix is the drug of choice.
And both these medicines obviously must be taken only after advice from the doctor.
Yes, absolutely. And one more thing about indapamide is that it should not be taken at night time. Because I've seen many doctors prescribing indapamide or diuretics like CTD or chlorthalidone or Pelma H in the night time. So diuretic should not be taken at the night time. What happens is, because it causes increased urine, you'll have to get up multiple times in the night and go to the washroom, which may disturb your sleep. So it's very important that any diuretic, which I used as a hypertensive or as a heart failure medication, should be used early in the day. Second advice is, whenever you use a diuretic and you're supposed traveling, don't take the diuretic and go, because what will happen on the way, you'll get a lot of urine to pass, and then that becomes embarrassing. So whenever you take a diuretic, it should be after going to the place where you have access to washroom. So these are two small things, but very important things when you are on a diuretic.
Right. Doctor, there's a question that has come in from somebody who says that, Doctor, my son is 41 years old and he snores a lot. He doesn't seem to have any medical condition and all his levels are fine. But in the long run, is it a better, how does one control snoring, etc.? Because especially because you mentioned that it could be one of the causes of heart failure.
Yes. So snoring, essentially, let me explain the physiology of sleep. So whenever we sleep, there are 4 phases of sleep. That's phase 1, which is light sleep. And deeper you go to the stage 4, it's the deep sleep. This is called as NREM sleep, non-rapid eye movement sleep. Okay. So the number of times you reach in the night time, this stage 3 and 4, you get the feeling of freshness. Okay. The freshness that I completed my sleep. Now, what happens is people who snore, there's a tongue fall, the airway gets narrowed, and the oxygenation and carbon dioxide levels, they go haywire. So the carbon dioxide levels in your body builds up, and this prevents the patient to go into deep sleep. So they are all light sleepers. They would snore, but even a small pin drop anywhere, they'll get up. And they'll snore the entire night and get up in the morning and say, I have not slept at all. Because they've not got this deep sleep, they've not gone in this 3 and 4 stage. And secondly, what happens is when you snore in the night, as I told you, carbon dioxide level builds up, and carbon dioxide has this tendency of causing vasospasm. So the blood pressure in your body goes up. And because of that, in the night time, you might get up, with sweating. And many times, many people have this. They get up in the morning and they'll say that my shirt was wet or my t-shirt was wet. So this happens because of snoring. And one of the most common cause we see is morbid obesity. So people who are obese have this tendency of sleep apnea and snoring. So if he snores a lot, if he has typical sleep apneic symptoms like early morning somnolence, he gets up, he doesn't feel fresh. Second, somnolence throughout the day, uncontrolled blood pressure, getting up in the night with perspiration. All these things are classical of sleep apnea. So he should get himself checked with a sleep study.
Thank you. So there's a question from Zareen Shah. Why does the pressure go down? How can it be brought up?
Okay. So normally blood pressure, the most common thing why people come to me as a cardiologist with low blood pressure is blood pressure medication. So BP medicines, if they are taken inappropriately, that means they've taken 2 tablets, or maybe because patient has exercised normally or taken less of fluids, what happens is the blood pressure medicine becomes more effective, and because of that your BP goes down. That's the most common I see as a cardiologist. I have people coming to me with hypertension. The second thing is if you have hormonal disturbances. In that case also you can have your blood pressure going down. So any thyroid issue, if there's central hypothyroidism, or there is cortisol, the steroid hormones in your body, if that's an issue, or there is something called as aldosterone. So any endocrine issues, if there is low salt, there is tendency of throwing salt from your urine out. So any salt disturbances can also give rise to hypotension. Third is what we commonly see is dehydration. In summers, patients take blood pressure medicine, but they're not drinking enough water, and because of that, the blood pressure can go down. So there are multiple causes, but you need to evaluate a detailed history, and investigations will take you to why the blood pressure has gone down.
Thank you. There is a question from an anonymous attendee. She is female, 77, had stroke 7 years back and is diagnosed with bradycardia. What caused the stroke? The heart condition or the stroke? Or the stroke caused the bradycardia, and she has a pacemaker.
I did not get the question. Is she asking me that low heart rate or bradycardia is causing stroke? Or no, that's not the case. So there might be an association. So stroke could be, multiple reasons. The most common we see in elderly is if there is any blockage in the artery supplying the brain. If you have any issue in that case, then you can get stroke. But there's a second cause, which is very common for what we see as cardiologists, cardioembolic stroke. So what is cardioembolic stroke? Is if you see the entire system, the heart is a chamber. The rest of things are tubes. They are arteries and veins. So heart is only place wherein the blood can hold up and cause clots. This happens in something called as atrial fibrillation. So patients who are slow heart, They also sometimes the heart rate goes fast. This is called a sick sinus syndrome. And so they get something called as atrial fibrillation. Atrial fibrillation means your heart normally is very synchronous. So lub and dub, this keeps on happening. But in atrial fibrillation patients, because of uncontrolled BP, sleep apnea, which we discussed, the heart fibrillates. And so when the heart fibrillates, the blood has a tendency, wherever it stops, it will form a clot. If you give a cut on your skin, if it stops, it will form a clot. In the similar way, in the heart, if the heartbeat goes very fast, but it's ineffective pumping. It does not, the blood does not egress from your heart completely. The blood has a tendency to form a clot in the chamber. And the most common part in the heart where the clot can form is the left atrial appendage or the left upper chamber. And once the clot is from there, due to some reason it moves out of this place, it can go up and cause a stroke. So atrial fibrillation undiagnosed can give rise to something called as a cardioembolic stroke. So that means the clot is formed in the heart and it's gone up and caused a stroke. So that is possible when you have a sick sinus syndrome, that is low heart rate and fast heart rate both together occurring in the same patient. So there might be an association.
Thank you. We have a question from Shrikant Kulkarni who says, I have been advised telmisartan 40 mg BD. I take that after breakfast and after dinner. However, I feel sleepy a bit after taking it after breakfast. Is it normal?
No, you should not feel sleepy. You should feel fresh. I mean, any tablet, any intervention, anything in life should make you feel good. It should not make you feel sleepy. So what my advice to you is, you need to check your blood pressure at that time. Or maybe there's something else to it also. Sometimes if your sugars go haywire or your sodium goes low, so that can also give rise to sleepiness. So you need to check for other causes. But telmisartan per se, sleepiness is only one thing which comes to my mind is the blood pressure going down. So just check your pressures whenever you feel sleepy or giddy.
We have a question from Mr. Suresh Ghate who says he's 70. 3 weeks back, he underwent a valve replacement surgery. Now improving. No diabetes, not obese. Now under Nabicard 2.5 and Laxis half tablet. What are the precautions besides a healthy diet and timely checkups to be done? He says other medicines that he is having are Acetrom 75 and Ecosprin 75.
Okay. So I don't know which type of valve he's undergone. If he wants to discuss, he can do that later on. But there are two types of valves. One is the bioprosthetic valve and the second is a metallic valve. So what is a bioprosthetic valve? Basically, it's a bovine or a porcine valve. That means it's a cow or a pig valve, which is inserted. Okay. So the beauty about this is you don't require to take blood thinners, especially something called as Acetrom, which is a heavy thinner, lifelong. You can just give it for 6 months and stop.
He just responded.
But what happens with the metallic?
Sorry, he just responded saying metallic valve.
Metallic valve. So very important that he should keep his. So there is something called a PTINR. That is in a metallic valve, you need to keep your blood thin, and it's not just like aspirin that you take it and you forget it. You need to monitor it, because what happens is when you take Acetrom, your blood gets thin, but how much thin? That's also very important. You need to keep your blood 2.5 times thinner than a regular individual, and PTINR is the test which you need to do. So PTINR regularly to be done till about the patient's PTINR is 2.5. That means 2.5 times thinner than the regular blood. And then after that, he can repeat it as per the advice of the surgeon. Or what I do with my patients is every 2 to 3 months, I repeat my patient's PTINR. So that's very important. Second, whenever he's on a thinner, he needs to take care. Brushing of the teeth is very important. What happens, we get our dental caries, and when we age, we can have the gum involvement. So if he should not brush his teeth very hard. So soft bristles, change of toothbrushes is very important, because this thinner is a very heavy thinner. Third, he should take care about falls. And he should protect himself, especially nighttime in elderly. When you get up, you might get giddiness or a fall. So that's very important, because any fall here on thinners can be an issue. So all these precautions need to be taken. Otherwise, Acetrom, Ecosprin, Lasix, and Nabicard is good enough. And he should have his regular blood test done, especially PTINR. And healthy diet is for everyone. It's for me, it's for you, it's for everyone.
Right. We have a question from two more questions, Doctor. One is from Sumer Jain, male 80. How much time does it take to reach all this or latest treatment to most hospitals. I live in Faridabad, which is 40 kilometers from Delhi. Many hospitals do heart operation. I'm not very sure what his question is, but the overall thing is, this healthcare facilities that you spoke about, heart transplant, etc. How much is it available in our hospitals across the country?
So heart transplant is not like, today if the doctor advises me heart transplant is going to happen tomorrow. Even if I have all the money available with me, it does not happen tomorrow. So you have a list of patients who are on the list, number 1, 2, 3, 4. So as soon as a heart is available, like now we had an 18-year-old heart which we brought in from Gujarat and transplanted it in a 13-year-old in one of the hospitals. So that girl was on the list and she got a call, she got ready. So the heart transplant was done. By God's grace, she's doing very well. So the heart transplant cannot be done, the next day, even if you have all you have to wait for the list. And heart it's unlike the kidney, a single organ. You cannot donate a heart, right? I mean, kidney, you can donate one kidney. You can live with one kidney. But heart, the patient has to be brain dead and the relatives have to be willing. The problem with our society is that, even in brain dead patients, when you counsel them, many of them are not ready to donate. The organ donation is the sarvocha, dan, according to me, and it's going waste. When you die, your organ, some younger patient or some individual might require it. It just goes away. So coming back to the point, heart transplant is happening, but it's happening in big centers, and it's only happening in metros. And there is a certification which has to happen for a particular center to be a cardiac transplant unit. So it's that. Second is patients who are on the waiting list but going into recurrent heart failures. Now, as I spoke, HeartMate 2 and HeartMate 3, these are assist devices. They are like, a peripheral, a heart with, the supportive heart. So that you can, if you have around 50 lakhs to 1 CR of insurance, which is beyond the reach of many individuals in our country, most of the individuals in our country. In that case, if you're on the waiting list, you can be on the waiting list, but you can go for these assist devices. So that would be the way in patients who are on maximal medical management, still going into recurrent heart failures. These would be the therapies, LVADs, that is left ventricular assist device, and heart transplant.
Doctor, we have, I had said only one more question, but there are two more. There's one from Katie Dalanchi. She says, Doctor, my 76-year-old husband is on amlopin 5 mg since many years. When we check his BP at home, it is 110/69. Is it okay, or should the tablet strength be lessened? His pulse rate is within normal limits.
How much of amlodipine, she said?
Amlodipine, she said, was 5 mg.
5 mg. So 110 is slightly low. I mean, I think the age is 70 odd.
That's right, 76.
76. So I would not keep 110 blood pressure in a 76-year-old, because the guidelines tell you in a near 80-year-old, even a 150 is acceptable. So 110 can sometimes cause giddiness and postural symptoms. But I think it would be better that she consults somebody, or she'll come for a consultation and maybe decrease the dose. But this has to happen with a registered medical practitioner's guidance. Any dose change cannot happen like this. But yes, I wouldn't keep 110 blood pressure in a 76-year-old. I'll keep it a bit liberal. 130, 140 would be my target.
So does it require immediate attention?
If he has symptoms and this thing, yes, I think she should go to the family physician and get the dose changed.
One last question. Anonymous attendee, male 69, BP, diabetic, bypass surgery 22 years back, triple vessel, 2D echo, ejection is 46%, 45% checked every year, constant at 45%.
Okay, so that's good. That's pretty good. That's pretty good. Well, so what are the important things? The important things are to check blood pressure. Blood pressure is good. Heart rate should be between 60 to 80. Your cholesterol, which I told last time, LDL cholesterol should be 50. And your HbA1c, because you're a diabetic, should be less than 7. So these are the 4 targets. If you achieve, you will stay away from heart disease happening again.
Right. One more person has asked a question, which is a good blood thinner? I'm not very sure whether you want to take brand names, But I guess, if you could just give a general response.
Also, a concept about blood thinners. So there are two things here. One is primary prevention and secondary prevention. So what is primary prevention is you have not had any stroke or heart disease, but you are starting a thinner. And secondly is secondary prevention. That means you had a heart attack or stroke and then you started a thinner, right? So in primary prevention, in patients who are non-diabetics, we don't have good evidence to start thinners, whatever the age may be. In diabetics, in high-risk subsets, what the US FDA and the guidelines tell you that in high-risk subset, you might consider, it's not that you have to, you might consider. This is for primary prevention. That means you have not had any disease, but then you are starting a thinner. So aspirin is time-tested for patients who have had gastritis or GI bleeds. It is clopidogrel. Similarly, in secondary prevention, again, it depends on if your stent has been put, whether it's 1 year since the stent has been put. So within 1 year, you will start 2 thinners. After 1 year, you will start one of the thinners will go on. So either aspirin or clopidogrel is in elderly would be the drug of choice. So I'm not asking for any. I'm not saying any brand. It's the content: aspirin, ecosprin, or your clopidogrel.
Thank you very much, Dr. Ankur Phatarpekar, for this session. Excellent and very informative session. We've answered also quite a few questions that have come in. And thank you once again for being here. Those of you who are here, you can pre-register if you want for our forthcoming sessions of Health Live at Seniors today. And you can we will put the code, the form over here where you can fill in, and we will pre-register you for all the forthcoming sessions of Health Live at Seniors today. The form is here, and you can fill in. Thank you once again, Dr. Ankur, for being here.
Thank
you. Just one last question. There's somebody who sent, Doctor, how is it that we can connect with you? Is there, you are there, the Symbiosis Hospital, as well as the Wokhart hospitals, and you also mentioned Reach Candy. How does one contact you if one?
So I'll share my phone number, and my phone. Should I write here?
Yeah, you could put it in the chat.
So I shared my phone number. This is my phone number. You can call me, or you can WhatsApp me, or you can message.
Yeah, I think if Dr. Ankur is in the cath lab, obviously he will not be able to respond to you. But I do know, I can tell you for sure that he does respond to messages, etc. So please feel free. We will of course have the recorded video of this session on Monday on seniorstoday.in, as well as the takeaways from this session. So both of them will be there. We will also put the phone number there, which is 98203 847 743. And thank you once again, Dr. Ankur Phatarpekar, for this session. And thank you, everybody. We will be back once again next Saturday at 5 p.m. for another session of Health Live at Seniors Today. Thank you very much.
Thank you. Bye.
Subscribe now and press the bell icon. Never miss an update.